Hello, welcome everyone. Thank you for joining us today for our webinar on COVID-19 and family planning. Today, we'll be connecting the dots between the data collected so far during the pandemic and the experiences of programs that have adapted their family planning services. Our goal is to find out what the impact of COVID-19 has been on family planning access and use around the world. My name is Ruwaida Salem, and I'll be moderating today's session. We're going to get started with some housekeeping issues and introductions while we wait for others to join us. Please go ahead and introduce yourself in the chat box and where you're joining us from. So we are providing two-way French and English interpretation during this webinar. We encourage all listeners to click on the interpretation icon at the bottom of your Zoom screen and then click on the language of your choice, either English or French. You'll then have the option to mute the original audio so you don't hear that in the background. Because we are providing live interpretation, you may notice that we are speaking a little slowly and pausing before we transition to the next slide to give our interpreters a chance to catch up with us. You may also select whether or not you would like to read captions in English during the session. You should be seeing these captions automatically, but if not, you can select them by clicking on the icon with the two C's at the bottom of your Zoom screen. If you wish to hide the captions, please select the same icon and select Hide Subtitle from the menu that appears. These captions are generated using an automatic feature in Zoom, and so they might not be 100% accurate. And on the Zoom platform, captions are only available in English at this time. Finally, we are recording this webinar and we will be emailing the recording out later today or tomorrow. As I mentioned, my name is Ruwaida Salem and I'll be moderating the event today. I'm a senior program officer and the Knowledge Solutions team lead for the Knowledge Success Project. Joining me today is Catherine Packer, Senior Research Associate in the Reproductive Maternal, Newborn, and Child Health Division with FHI 360, who led the data analysis and synthesis for connecting the dots. I'd also like to acknowledge Allison Bodenheimer, the FP Technical Advisor for Knowledge Success, who synthesized the program adaptation experiences that we'll be sharing with you later today. So here's the plan for our session today. I'll start with a brief overview of what connecting the dots is and why we chose to focus on the impact of COVID-19 on family planning. Then Catherine will review the findings, and you all have a role to play here too. Catherine will pose some questions to you about the impact of COVID on FP, and will ask you to respond through a series of poll questions before she shares the data findings. We also have plenty of time at the end of the session to take questions from the audience. Please feel free to add your questions to the chat box throughout the session, and we'll answer them at the end of the webinar. We have several of our partners that collaborated with us on connecting the dots, including PMA, Breakthrough Action, and Access Collaborative, on hand to answer some of those questions before we end with closing remarks. So let's get started. At the beginning of the pandemic in April 2020, UNFPA estimated that if COVID-19 related disruptions in health services continued for 6 months, 7 million unintended pregnancies could occur. However, estimates from 1 year into the pandemic put the figure closer to 1.4 million. While this number is still troubling, it indicates that the impact of COVID-19 on unintended pregnancy during the first year of the pandemic may not have been as dire as originally feared. It is with this context that we sought to take a deep dive into the latest evidence and experience data to understand what was going on. We knew that program managers and technical advisors and family planning professionals around the world had many questions about the pandemic's impact on family planning programs. So we aimed to answer some of these questions, including, did pregnancy intentions change due to COVID-19? Similarly, did contraceptive use change due to COVID-19? Were women able to access family planning services during the pandemic? How did family planning programs respond to the challenges of the pandemic? And importantly, what lessons can be applied to future pandemics or crisis situations? How did we go about answering these questions? Well, first, we synthesized data from national or subnational surveys, and we also looked into the implementation experiences from programs that have adapted their services. We are publishing all of these important data and information into an interactive visual experience online that we're calling Connecting the Dots. As mentioned, we worked in collaboration with several partners. For example, we worked with PMA to analyze data from national or subnational surveys from 7 countries. The specific survey dates vary by country, but in general, they occurred between November 2019 and October 2020. And they represented either 2 to 4 months before the pandemic started in those settings, early in the pandemic, about 3 to 4 months into the pandemic, or later in the pandemic, sometime between 6 to 10 months into the pandemic. In 4 settings, Burkina Faso, Kenya, Kinshasa, DRC, and Lagos, Nigeria, there were 3 surveys that we looked at. In 3 other settings, Côte d'Ivoire, Rajasthan, India, and Uganda, there was 1 survey available to us at the time that we undertook this work. So we selected 4 key indicators to explore, and PMA prepared the data. PMA collects many other indicators in these surveys, of course, but we chose these 4 key indicators to illustrate the impact of COVID on family planning. It should be noted that the earlier COVID survey was done by phone, and so the sample size was smaller as it only included those with access to phones. So this may have impacted the results in that particular survey. My colleague Allison also worked with 3 programs to document and share their experiences with adapting their family planning services during COVID. For Côte d'Ivoire, we worked with Breakthrough Action and West Africa Breakthrough Action, or WABA. For Madagascar, we worked with Access Collaborative, which is implemented by PATH and JSI. And for Nepal, we worked with the Family Planning Association of Nepal, or FPAN. These experiences are not tied to the PMA survey data, but they do help shed light on some successful adaptations which add more context to the overall survey findings. Here's a preview of what an interactive chart and connecting the dots will look like. This is an example of PMA data from Kinshasa, DRC. People can choose the indicator of interest and visually see how the situation changed or didn't change over time within the background COVID-19 context. We are currently finalizing the charts as we speak and expect to publish the interactive piece in January. Because we know these issues are top of mind for many people, we decided to convene this webinar now to preview the findings before we close out the 2021 calendar year. And with that, I'd like to pass it to Catherine, who will now share our findings. Catherine?
Great, thank you so much. Okay, so what did we find? Now we're going to go through some questions, and for each one, there will be a poll which we would like you to fill out. Then on the next slide, we will reveal what we found. So here's the first question, and there should be a pop-up on your screen with some responses. So have women changed their minds about wanting to become pregnant because of COVID-19 concerns? And the responses are yes, there were large changes. Yes, but the changes were small. No, there were no changes. So please select what you think is the correct answer. Great, so answers are coming in. Give a few more seconds. All right, so it looks like most people are saying yes, but the changes are small. So moving to the next slide, we will reveal the answer. And you're right. So yes, but the changes were small. What we found from looking at these data was that overall there were changes, but they were smaller than we expected they would be. So this graph shows the percent of women who reported that they changed their mind about wanting to become pregnant because of COVID-19 concerns. Note that the survey question is framed as a yes or no question. So we don't know whether women changed their mind to preferring to delay pregnancy or to become pregnant sooner. Interestingly, in the four settings, sorry, one second. Interestingly, in the four settings that had multiple surveys, the percentage of women reporting that COVID-19 concerns changed their mind about wanting to become pregnant decreased between the first and second surveys conducted during COVID. One exception to the small changes was that more than 20% of women in Burkina Faso said that they changed their minds at the earlier survey, but at the later survey, fewer than 10% of women reported this. Okay, so the next question is, did contraceptive use change during the first year of the COVID-19 pandemic? And the responses are yes, contraceptive use increased. Yes, contraceptive use decreased. No, there were very few or no changes. So we'll give a few seconds for the responses to come in. Okay, it looks like most people said yes, contraceptive use decreased. So that is definitely what I would have thought too. Interestingly, looking at data from the 4 settings with multiple surveys, we actually see very little change in contraceptive use between pre-pandemic, earlier and later COVID surveys. This graph shows the percent of women at risk of unintended pregnancy who were using any modern or traditional contraception at the time of the survey. You can see slight variation in the patterns between the countries, but in all 4 cases, compared to the pre-pandemic survey, contraceptive use was actually slightly higher or the same at the survey that took place 8 to 10 months into the pandemic. Okay, so we just saw that the percentage of women using any contraception in those 4 settings did not really change. That indicator included both modern and traditional contraceptive methods. But what do we know about method switching? Did these women switch to less effective or no methods during the first year of the pandemic? The response options are yes, many women switched to less effective methods or no method, or no, there were not large changes to switching methods. All right, so it's looking like most people think that no, there were not large changes to switching methods. And that is correct. Again, looking at the data from the 4 settings that had multiple surveys, they showed that fewer than 1 in 5 women in each setting changed to a less effective methods or no method between surveys. However, there were slight increases at the later COVID survey in 3 of the settings, which potentially indicates a worsening situation. All right, so the next question is, did COVID-19 related reasons impact women's access to contraception? So reasons included the contraceptive product not being available, the facility being closed or services not available, government restrictions, fear of becoming infected with COVID at a facility. And the response options are yes, COVID-19 greatly impacted access. Yes, but the impacts were greater at the beginning of the pandemic. Yes, but the impacts were greater further into the pandemic. Or no, COVID-19 did not appear to impact access. Okay, it looks like most people think that yes, but the impacts were greater at the beginning of the pandemic. So that's interesting because I guess it really depends how we define beginning or further into the pandemic. We found that the impact looked to be greater further into the pandemic, but that's still somewhat early in the pandemic if you think about how far in we are now. So looking at the data from all 7 settings, from women who were at risk of unintended pregnancy but not using contraception, very few women cited COVID-19 related reasons for contraceptive non-use at the earlier COVID survey in 3 settings, but this increased by the later COVID survey in those settings. And in the 3 settings with a single COVID survey, which took place 6 to 8 months into the pandemic in those settings, a substantial percentage of women not using contraception cited COVID-19 related reasons for contraceptive non-use. These data suggest that COVID-19 may have had larger impacts on contraceptive non-use later in the pandemic than earlier. We note that nearly half of women not using contraception in Kenya's second survey and in Rajasthan, India's survey, reported COVID-related reasons for non-use. All right, so this is the last poll question. Were there differences in these indicators by subgroups of women? So we examined the data disaggregated by age, rural versus urban residents, and number of children. So the responses are yes, there were differences between subgroups, and no, there were no differences. Great, so it looks like most people think that yes, there were differences between subgroups. We agree. When looking at the data disaggregated, there were some subgroup differences depending on the indicator, but they were not consistent across countries or even within a country across time points. So one example is when compared to the total population of women, a higher percentage of certain subgroups reported not using contraception for COVID-19 related reasons. The specific results are shown on this slide, but as you can see, in one setting, it was women with no children who were more affected, whereas in another setting, it was women with 3 or more children. In yet another setting, it was younger women, and another older women. So this highlights the importance for those working on programs to dive into subgroup level data where available to make sure that we are not missing any important differences. All right, thank you so much for your responses to the interactive polls. Really great to get your participation. So now I'm going to talk about 3 case studies we did for connecting the dots of successful programmatic adaptations. In-depth descriptions will be available in the online experience, but I'd like to present a snapshot of these here. All right, so Breakthrough Action and West Africa Breakthrough Action broadcast a radio campaign called Confiance Totale in 4 Francophone West African countries, including Côte d'Ivoire. The goal was to improve demand for family planning services by educating clients about safe, effective family planning in a supportive social context. The project originally developed 2 Confiance Totale radio public service announcements, or PSAs, which focused on trust in family planning methods and services, couple communication, and joint decision-making about family planning. At the onset of COVID, anticipating disruptions to access of family planning services and methods due to lockdowns, the project team pivoted their approach and produced a series of 7 additional radio PSAs. These new PSAs retained the focus on trust in family planning methods and services, couple communication, and joint decision-making about family planning, but framed them within the COVID context by addressing hesitation about visiting health centers and restricted movement. For example, one message focused on using this extra time together at home to discuss birth spacing with your partner. Another focused on continuing to use family planning successfully without going to the health center by using call-in numbers. The radio campaign ran in urban areas in and outside of Abidjan from May to September 2020, so for about 5 months early in the pandemic. There were 3 waves of monitoring from 1,000 men and women, so a total of 3,000, and on average, 61% of respondents were using modern contraception. It should be noted that the exposure to the campaign messages was lower than expected at less than 20% of respondents exposure to the campaign, rather than around 30 to 40% expected, which may have been due to the monitoring platform or unrest during the election season during the time of the monitoring waves. Nevertheless, the results suggested that exposure to the campaign was associated with positive family planning outcomes. For example, men and women who recalled hearing a campaign radio PSA at least once a day versus not at all were more likely to be currently using family planning and more likely to intend to go to a health facility to seek family planning information in the next 6 months. So you can actually access those radio spots on the Compass website. The link will be dropped into the chat, and you can find adaptations for other countries and in other languages. They're pretty fun to listen to. Great, so the next case study is related to self-injection of DMPA-SC, which can be particularly useful during a pandemic, as it enables women to avoid going to crowded facilities, since they can take home multiple units to self-inject and be covered for pregnancy prevention. In Madagascar, DMPA-SC self-injection was first introduced in March 2020, right at the beginning of the pandemic. Because of this timing, the Madagascar Ministry of Health and Access Collaborative developed an innovative model of remote supervision for providers using phone simulations, as well as adapted training materials and protocols for family planning providers. Once providers were trained to teach women how to self-inject, a supervisor would call a provider on a basic phone, and the provider would simulate training a client to self-inject by verbally sharing how they demonstrate the self-injection steps using a model, which was a condom filled with salt, and answered questions. In this way, 100% of providers were successfully supervised remotely, whereas in-person supervision prior to COVID reached only 40 to 60% of providers. And almost all the providers, 93%, highlighted the key steps for self-injecting during those supervision calls. This approach enabled successful introduction and scale-up of DMPA-SC self-injection despite the COVID pandemic. So further showing that, here's a couple data points I'll walk you through. As of April 2021, 52% of public service delivery points were offering DMPA-SC, and this was up from 42% in December 2020, and it exceeded the goal of 50% offering DMPA-SC by July 2021. Also, there were nearly 5,000 self-injection clients by April 2021, compared with about 2,500 in December 2020. These data suggest that remote supervision is feasible and enables supervisors to oversee providers' counseling skills. Our final case study takes place in Nepal. Using emergency funding provided by April and September 2020 with the support of the Australian government, FPAN was quickly able to reestablish family planning services early in the pandemic. FPAN worked closely with the government of Nepal on a national directive that emphasized adapting services safely, such as through the use of telehealth. FPAN also issued its own operational guidance to deliver sexual and reproductive health services, focusing on the needs of underserved and marginalized groups, such as adolescents and migrants. FPAN was the first organization to resume essential sexual and reproductive health services. Almost all 29 of their service delivery points resumed essential services within 1 month of the national lockdown. Key service adaptations included a higher reliance on the existing community-based distribution approach, the use of digital media, rigorous oversight for an uninterrupted commodities supply chain, and staff support through provision of protective gear and incentives, such as a hardship allowance. This resulted in comparable numbers of clients served as before the pandemic, which I'll show you on the next slide. So you can see here on this line graph that there was a steep drop in clients accessing FPAN's SRH services at the start of the lockdown in April 2020, but the numbers rose quickly and consistently in the following months to near pre-pandemic levels. In July, when the lockdown ended, we see the numbers drop off a little, possibly due to alternative service delivery points becoming more available. And as a reminder, this graph is just showing the clients being served through FPAN services. So overall, these data suggest that the Ministry of Health's directive on essential family planning services and FPAN's operational policies, coupled with emergency funding, were instrumental in ensuring the continuity of family planning services in Nepal early in the pandemic, even as lockdowns were occurring. Tying it all together, what lessons have we learned about continuing family planning services during a pandemic that we can apply for the future? As I'm sure we all know, it's a variety of policy and programmatic adaptations to family planning services and the supply chain, which can help ensure continuity of family planning services during pandemics and crises. I'm going to briefly describe some of the most prominent factors that we found in our synthesis. The WHO and national governments deeming sexual and reproductive health services essential was a critical first step to ensuring continuity of services. This included deeming certain contraceptive products as essential medicines or deeming sexual and reproductive health providers as essential service providers. Also, proactive management of stocks of family planning commodities helped protect against stockouts early in the pandemic. The Reproductive Health Supplies Coalition has a great report about this, and I believe we'll drop the link into the chat, which also showed resilience of supply chains in several countries early in the pandemic. As presented here with the case studies, COVID-19 actually spurred some pretty creative and successful adaptations in family planning programs and service delivery, which contributed to continued contraceptive use. And finally, innovative data collection methods, such as using remote data collector training or phone interviews, made it possible to collect critical data to understand and respond to the pandemic to inform family planning programs. In summary, this synthesis of PMA survey data and program experiences shows that it appears that COVID-19's impacts on contraceptive use during the first year of the pandemic may not have been as severe as originally feared. Program and policy adaptations, many of which can be applied to future pandemics or long-term disruptions, contributed to the continuity of family planning services in early phases of the pandemic, enabling women to continue contraceptive use. But the pandemic is not over. The data we just shared are only from the first year of the pandemic and from a limited number of countries, mostly in sub-Saharan Africa. COVID-19 may have had and continue to have more severe effects on family planning services and use in other regions of the world or in other countries not included in the analysis. There were some indications in the PMA data that the COVID-19 situation was worsening, such as more women not using contraception for COVID-related reasons in some countries 6 to 10 months into the pandemic. And it also may continue to get worse. Despite its devastating effects, the COVID-19 pandemic spurred innovations in programs and policies that may not have been otherwise attempted. Many of these adaptations have been successful enough to continue in some form and are anticipated to continue even after the situation is back to normal. As 2021 is coming to a close and we take stock of where we started at the beginning of this unprecedented pandemic, we as a family planning community should feel proud about the hard work and endurance to provide women and men with much needed services. Although we don't know what the future holds, the synthesis demonstrated resilience of family planning users and programs And we hope that you all can use these learnings in positive ways moving forward.
Great. Thank you, Catherine, for sharing those findings and for that message of hope and resilience for all of our colleagues on the line. We'd like to open it now to answer questions from the audience, and we've seen several questions come into the chat box, so thank you for that. We also have on the line with us several of our partners, including Celia Karp from PMA and Erin Portillo from Breakthrough Action, and Caitlin Cornelius from Access Collaborative, and I believe Avotina Rakotamanga from Access Collaborative is also on the line. So we'll start with a question from Sophia. Catherine, I'll pass this to you first. When you explored how many months in that women experienced COVID impacts on family planning, what was the baseline? Was it from March 2020? So can you address the timing of those baseline surveys?
Sure. So it varied by setting. In 4 of the settings, there was a pre-pandemic survey, which took place between 2 to 4 months before the pandemic started in that setting. So for example, they were all African countries, and pretty much COVID started in about March there. So those surveys took place in like December for those.
Great, thank you. And then a related question on the data. When you explored whether women switched to less effective methods, how did you define what less effective methods were? Was it short-term methods, or what was the specific definition
Yeah,
for that?
that's a great question. I can pull up the answer to that. So contraceptive users were placed into 3 groups based on the effectiveness of the method they were using. More effective methods included implant, IUD, sterilization. Effective methods included injectable, pill, diaphragm, and less effective methods included condoms, lactational amenorrhea, standard days method, emergency contraception, traditional, and other. And women who reported using sterilization were excluded in the calculation of women transitioning to less effective or no methods, since they were not at risk for this outcome.
Great, thank you, Catherine. Since we're on the data, maybe I'll pass this one to Celia. Celia, what additional COVID surveys has PMA published since the time we've worked on this piece? And are you finding similar trends continuing in the later surveys that you've conducted, or are you starting to see some shifts?
Yeah, thanks so much for the question. In the later COVID surveys, those are our phase 2 surveys that were implemented about a year after the baseline surveys and the COVID-19 follow-up surveys that Catherine presented on. We're actually seeing the same trends, and particularly the trends related to increased contraceptive use overall in 4 of the countries that were presented. And this is a really interesting finding, I think, because there was a lot of stipulation about those COVID-19 surveys. As Catherine mentioned, they were implemented via phone in order to accommodate changes that were needed due to COVID-19 precautions. So the fact that now, a year later, we're still seeing the changes that were identified during that phone-based follow-up survey kind of indicates that the patterns that we were seeing are sustained over time. In 2 countries, we were actually looking at the changes from provider-dependent methods in terms of understanding that some women might have been less likely to access methods that required them to access facility-based services. And in 2 countries, we were seeing a very slight decline in the proportion of women who were reported using provider-dependent methods. So some differences and changes a year later, but overall, mostly kind of the same messages in terms of key takeaways that Catherine highlighted today.
Thanks, Celia. I'm going to pass this one to Avotine from our colleague from Madagascar. This is from Rachel. What strategies have been put in place in Madagascar to ensure that health facilities take up DMPA-SC so effectively?
Oui, merci pour la question.
Yes, thank you for this question, Rachel. I'm Avotina with Access Collaborative from Madagascar. In fact, I think that we have talked here about a DMPA-SC that is self-injected. All of the pharmacies offer this method, but maybe it's more a question of accepting use of this or taking on the responsibility for self-injection. So to respond to Rachel's question, self-injection is something that we very much took up, and the Ministry of Health really took on the responsibility to encourage self-injection and to work from this approach. And so this became an integral part of the family planning program in Madagascar. And we wanted to be sure to continue to encourage and to support self-injectables and to continue to promote this kind of contraceptive method. During the pandemic, in addition to the Ministry of Health taking ownership of this, we also had the Secretary General who also was promoting this. And now we have different health trainings for different districts that also present information about self-injection. We have moved forward in phases. So all of the districts did not start doing this at the same time, but they started doing it gradually. So this allowed us to continue to monitor the changes and to control the implementation of this program where we were offering more self-injectables. Furthermore, I'd like to add, and I'd like to thank our colleagues who mentioned that we have learned so much from this difficult period. We've recognized that it is an opportunity for us to innovate and to also encourage women to go to more health workshops. And this was an important opportunity for the Ministry of Health's team. Once women had seen the presentations, once they accepted self-injectables, then after a few months, after 6 to 9 months, these women, that was the only time that women needed to come back to the center. So that was able to limit some of the comings and goings of women, so they weren't required to come back as frequently. So this was also something that encouraged the government to promote self-injectables during the pandemic. And this was important for the implementation. The ministry was working in partnership with Access Collaborative, and so we were able to take advantage of this opportunity in order to put these approaches into place, put them into action in order to promote self-injectables throughout the country. So I hope that answers Rachel's question. Thank you.
Merci, Avotine. Thank you so much for that. So our next question comes from Lorena. Do you think that the decreasing trend of the number of births in 2020 and 2021 in some countries would be attributed to contraceptive services? So Celia, would you mind taking that question?
Oh, oops, sorry, wasn't unmuted. Yeah, sure. So in terms of, obviously this is very country dependent, so I'm only speaking in terms of the 4 countries that Catherine presented on, for which we have the longitudinal data from before COVID, through these 2 time points during COVID and then the later COVID period. And our focus, in terms of measurement related to number of pregnancies, was actually about estimating the proportion of women who reported a pregnancy, that they had a negative reaction to a pregnancy, in terms of understanding if it was an unintended pregnancy, that when they found out about the pregnancy, they were unhappy about it. And this is because identifying the sheer number of pregnancies that are occurring may not be as important in terms of family planning if those pregnancies were wanted, if people shifted to wanting to have children. So in fact, we actually, recent analyses, we found that in Kenya, the proportion of women who reported that they became pregnant and were unhappy about experiencing that pregnancy actually decreased during the COVID period, very, very slightly. I think it was from 3% to around 2%, so very slightly. But those changes were significant. And I'm just highlighting that because this might reflect, as you're saying, some changes to contraceptive use that are happening in these contexts. So definitely important for thinking about both what we're considering in terms of is an increased number of pregnancies problematic, or is it actually reflective of what people want? And then how does that align with changes that we're seeing both in terms of availability of family planning services and also use of those services?
Great, thanks Celia for that insight. So we have several questions coming in about the initial UNFPA estimates, and why there was so much discrepancy between the initial estimate of 7 million unintended pregnancies and coming down quite substantially to 1.4 million unintended pregnancies. So Catherine, I don't know if you can shed some light on why there was such a drastic difference between those 2 UNFPA estimates, with like 1 year apart.
Sure. So the earlier estimates of 7 million unintended pregnancies were largely based on assumptions and hypotheses of what could happen if women could not access family planning services. So they were, based on assumptions and hypotheses, not actual data, because it was a prediction. The later estimates 1 year in did incorporate data on observed disruptions and changes in use of family planning services. And so that provided more of a concrete estimate.
Great, thanks.
Luckily was much lower.
Yeah, I think one of our colleagues dropped in a link in the chat to the UNFPA reports, and so their methodology is outlined in more detail there if you're interested to find out more. The next question I think I'll also send to you, Catherine, since we don't have a colleague from FPAN on the line. So if you can answer it, monthly monitoring of service statistics in Nepal has shown that FP service utilization was indeed affected. How can the data presented in this presentation on FPAN services be justified?
Well, this is just data from FPAN, for a certain time period. It's quite possible that other decreases were shown in other services, but we didn't look at those data.
Right. So yeah, that line graph that we displayed was just for FPAN clinics and service and community-based services. So they demonstrated that they were able to, provide continuity of services within that initial time period. Great. Next question comes about any differences in terms of quantity and type of contraceptives among younger age groups versus older age groups. So maybe I can pass this to Erin Portillo, based on your experience in West Africa through the Breakthrough Action Project. Are you seeing any differences in the types of contraceptives among younger age groups versus older age groups?
Thanks. This actually is not something that I don't have that information at my fingertips. I'm not sure that we were able to do any age disaggregation, but I can follow up on that with my research colleagues as well. Sorry to not be able to provide a more precise answer on that right now.
Great, no problem. Maybe Celia, do you have any insights on types of contraceptives between younger age groups and older age groups in general?
Yeah, so unfortunately, we faced a lot of similar challenges that maybe Erin's suggesting in terms of not being able to disaggregate to just that kind of 15 to 19-year-old age group that we do collect data on for these specific indicators. And it's something we're trying to start exploring, and we have some data that's specific only to youth in Nairobi. But unfortunately, that wasn't kind of the focus of this analysis. But I don't know, Catherine, maybe it's something that we can explore in terms of the interactive tool online. Thanks for the question.
Great, thank you. Next, Erin, I'd like to pass this one to you. Can you provide any additional updates on the Confiance Totale campaign? Are there any updates that you'd like to share? The last we spoke, I think you had plans to adapt the radio spots to Togo. So are there any updates that you'd like to share with us?
Sure, absolutely. We planned on actually a rebroadcast of those radio spots in Togo. Another difference, and thank you, I think it was Catherine, for explaining so nicely some of our limitations of our broadcast in Côte d'Ivoire, including kind of noise around the election cycles, and a couple of other factors. In addition, in Côte d'Ivoire, because of resources, we were only able to broadcast on local or community radio stations and not on commercial or national radio stations. And so in Togo, we will be rebroadcasting most of the spots using national broadcasts, and during a calmer political environment or context at the time. And so we've finished those broadcasts. We plan to start training researchers later this month, and we're hoping to have results of the Togo broadcast campaign towards the end of January, early February. So we will be posting, hopefully sharing those results on the Breakthrough Action website sometime in that time frame.
Great, thanks, Erin. Look forward to learning more about that. Next question, maybe I'll pass to you, Catherine, and then Celia can follow up. Did you notice a major difference between urban and rural areas?
It definitely depended on the setting and the indicator. So sometimes, yes. One thing that will be cool when we launch the interactive data experience is that you'll actually be able to download the data and look into the subgroup differences. But so for the countries that had like multiple time points, Burkina Faso and Kenya, you are able to look at urban and rural differences. And I mean, there was a really interesting thing with contraceptive use. Rural women in Burkina Faso really increased use between the pre-pandemic survey. So like 34% of rural women prior to the pandemic were using contraception. It increased to 48% about 3 to 4 months into the pandemic, and then was at about 42% later. And then in Kenya, it kind of stayed the same, had a slight decrease of rural women. But yeah, there are really interesting differences to explore, and we invite you to download the data in late January when it comes out.
Great, thanks, Catherine. And it seems like we only have a couple minutes left, so I want to thank everyone for your thoughtful questions. So we'll go ahead and wrap things up today. But we will be sending out written responses to any of the questions we weren't able to get to. So stay tuned for that. Next slide, please. So we invite you to continue connecting with our team to learn more about the pandemic and its effects on family planning. And you can do that on the next slide. In researching this piece, we've come across many useful resources, and we've collected all of those resources into an FP Insight collection. So FP Insight is the first resource discovery and curation tool built by all of you and for all of you. This slide shows a screenshot of the collection we created on FP Insight. So we invite you to explore that. We'll drop a link to the collection in the chat. Anyone can view the collection on FP Insight, regardless of whether you have an FP Insight account or not. But if you don't already have an account and are interested in learning more about FP Insight, we invite you to sign up for one of our interactive training sessions. In this 1 hour training session, you'll learn all the ins and outs of FP Insight. So you can find the day and time that works best for you for the training by clicking on the link that we'll drop in the chat. And finally, to close, just keep an eye out in your inbox for an announcement of when we've launched our Connecting the Dots interactive piece so that you can dive into the data and learn more about each country's data that we synthesized, as well as the 3 program experience case studies. And with that, I want to thank all of our partners who collaborated with us on this interactive piece and who made time today to be available to answer your questions. And thank you everyone for joining us for today's session. Have a great week, and I hope that 2021 brings us and the communities we serve around the world peace and good health. Thank you so much.